We will have question time to start off with for Dominic. Could you tell us if there's a correlation in viral load when somebody has a clinically evident lesion as compared to asymptomatic shedding? I mean, we tend to say if there's a lesion there, there's a lot more virus there. But would you like to comment on that?
I think in general terms, Suzanne, there is a strong correlation with the amount of virus shed from a clinical lesion compared to asymptomatic shedding. And there's also a time factor here, so how long the clinical lesion is been present also influences what the viral load is like. So in other words, when the lesion is fresh, the viral load is high and it drops. But I think it is worth saying that people can still have shedding at quite high viral loads in the absence of clinical disease. So.
Thank you. Next question is to Adrian Mindel. How can you explain the risk difference of HSV1 between men and women?
I think that's a really interesting question, and those data, I mean, I think would suggest that women are receiving oral sex more commonly than men are. Now, you know, whether that's true or not, I honestly don't know, and we haven't got those data to back that impression from the serology up. I think it's a really interesting question and something we need to do further studies on. And we know so little in terms of adolescent sexual behaviour in real detail. That's something worth certainly studying. So good question, but I can't answer it.
Okay, another one here is there any data on interaction between HSV and HIV in pregnancy?
I'm not aware of any data, but it's a good thought in terms of risk of transmission. I think that data would be available, but I haven't seen it published.
No.
Okay, the next question, I think this is for Darren. What do you recommend for management of HSV1 and HSV2 seropositive gay males, HIV positive or negative? Lifelong suppression?
Well, I'd like to thank Novartis and GSK and say yes. No, I think it should be seen as a potential risk factor for transmission of both, well, HSV1 and 2 obviously, but also HIV. So if a gay male is HIV positive and also has antibodies to HSV1 and 2, I think that should be seen as a potential risk factor, and that person may be at higher risk of transmitting. And if that person's in a serodiscordant, that is an HIV serodiscordant relationship, that person may want to consider suppressive therapy. The problem we have in Australia, of course, is that if the person is asymptomatic, it would be very hard to get that on the PBS. But I think, you know, lifelong suppression is not something that most people will take up, but there will be a place for those who could be at high risk of transmission. And we don't really have the data that reducing that risk or reducing HSV2 reactivations will reduce the risk of contracting HIV. Those studies are ongoing, but I think at a client level, at a patient level, it's something to consider.
I guess I'd confirm that, but I think it's reasonable to have a high index of suspicion of using suppressive therapy in HIV-infected people with clinical history of genital herpes, and particularly if the CD4 count is low. And it's worth just reflecting back on some very difficult data from years ago before antiretrovirals were widely available, and people were using high doses of acyclovir as a kind of management tool in end-stage HIV, and there was some sort of clinical benefit which was probably related to treatment of the herpes rather than treatment of the HIV.
This is an interesting question, and I guess it underpins a lot of the PCR work that we do today. With regard to shedding, is PCR too sensitive? In other words, do we have really a cut-off where we know this is an infectious dose or not?
Yeah, I don't know. I mean, I think you could. I think if you go back to the clinical issue, as Cheryl and I think everyone's said, we know that the bulk of herpes transmission is from asymptomatic people who are shedding. So therefore, detection of shedding is important. Now, what you don't know is how little virus or how much virus do you need to shed to cause infection. So I think actually, unlike a number of other diseases, I would have thought that PCR detection of shedding is important.
Now, this is another question for you, Dominic, that some patients never seroconvert to a fully developed HSV Western blot. How often does this happen?
It does happen. I mean, I think the type-specific serology in general is actually a little bit more difficult from the lab point of view than one might be able to express in talks. As you know, with HIV or any other situation where Western blots are used, it's a complicated serologic technique. It's generally less sensitive than perhaps the ELISA-based techniques, but is often sort of more specific for the disease of interest. But given all that, there are Western blots that don't fully evolve, if you like, to be a true positive, and it's also dependent on the quality of the Western blots that are produced, whether they're commercial or in-house and so on. There are a number of lab issues that make Western blot tricky, but it would be reasonable to say, well, at least in our hands, that at least 10% of Western blots are tricky to interpret. So then you're sort of stuck with, as I had in one of my slides, trying to interpret that in the context of the clinical disease you're managing.
And probably depends a bit when you're bleeding the patient relative to their outbreak, because it can take a while for Western blot to become positive. And certainly when I was working in Steve Sachs' department, working with a cohort of pregnant women, we found the occasional person who was culture positive who 9-12 months down the line had never made a positive Western blot, but that's pretty uncommon. And that was with Rhoda Ashley's Western blot.